Yes, good morning. This is video 13 on the Tulip Airway. This one is very specifically about rapid deployment. Okay, so we're talking about pre-hospital. This is what Tulip was designed for. This is what my ultimate goal is. Sure, you can use the Tulip in starved elective anesthesia in ophthalmology, in ENT without intubation and without paralysis, but this is what Tulip is for. It is to make airways easy for everybody, and the claims that I give you have statistical evidence or third-party proof. So everything I say to you is new, but it is all true. Okay, what we want to show is some accelerating critical care. I'm going to demonstrate how the Tulip Airway can dramatically reduce pre-hospital airway insertion times. Now, the focus is on procedural optimization, so basic life support ABC, and I'm going to show you how to use a Tulip in an emergency because it is proving to be a rapid life-saving intervention in a number of situations. Now, in emergency medicine, the airway ABC are the first two things that happen to you, so every second counts. Basically, the problem is that traditional intubation methods, they can be effective in the right hands, but they can be disastrous in the wrong. As I said, this is what Tulip is designed for. My father died in my hands after an esophageal intubation, and the Tulip is the consequences of that. Now, basically, this means that other airways can be time-consuming and ineffective, and a Tulip is just not. I will show you why. All right, this is my life's work. This is what Tulip does, and this is why it exists. If it can do this out of hospital, you know it can do starved elective sitting on its head. Well, here we have the situation. Basically, out of hospital collapse survival without neurological deficit is between 1.25 and 2.5%. But that is, I mean, that's cataclysmic, in my opinion. I think that's just not acceptable in the 21st century. And 98% of dying, I mean, it might as well be the Middle Ages, you know. Well, look, there must be an association with the fact that current ABC protocols usually include a Guedel mask as a start. Anybody who's not anesthetic can't use one. Now, I'm sure basically, you know, there are paramedics, there are nurses, there are a number of other skilled individuals who've learned and now can. But essentially, 41.7 to 45% of NHS staff fail even when they're trained how to use one every year. So it's not what we would call effective. Additionally, it was designed in 1933, so at 90, what is it, 2-3 years old? I mean, what else do we use that's nearly 100 years old? I mean, it needs replacing. So imagine this. What happens if there was an airway that did make a dramatic difference? Okay, I want you to imagine an airway whereby anybody can do it anytime, any place, whether they're the patient or the user. All right. What happens for example, today this is designed for everybody, but I need to speak to consultant anaesthetists because, ladies and gentlemen, I have to go through you before the benefits of a Tulip can reach the paramedics, the nurses, the recovery staff, the wards, A&E. So for the consultant anaesthetist, imagine that anybody can do an airway. Your staff will not have to leave theatres and attend on the wards. Now, I'm sure basic anaesthetists will always be required at, you know, CPR type scenarios, but airways in themselves were difficult because a Guedel mask is difficult. Imagine now airways can be done by anybody, anytime, any place, you know, including an 8-year-old child. Now, remember I said I would give you evidence of everything I claim. If you go to the Tulip website, you will see my son when he was 8 generating 30 and 40 centimeters of water. He, at the age of 8, could have resuscitated you. So that to me is proof positive that the 8-year-old child resuscitating a collapsed parent at home is an objective that has been achieved. Now, that's a Tulip. Now, what you've got is the blue and the yellow are both pediatric. The green, the orange and the red are basically small, medium, large in terms of the same colours in the UK of Goodell. Okay, there's another view of the orange and yellow. Okay, now imagine a critical incident. You've got seconds to react because a patient just can't breathe. So what happens if we could completely transform airway management? Do you think that we know everything, that everything is as good as it can be? Do you? Right, the Tulip Airway is designed for speed. The video will show you what to do. Please note that I'm using a 60ml, 50ml syringe here because adult tulips need 50 and 60 mils of volume, so don't use a 20ml 3 times, it will really slow you down. Notice also that when the cuff is inflated, there's a bit of a chin lift because the tulip sits in the oropharynx behind the tongue. This is the Tulip Airway. To insert, push down on the chin. Place into the mouth, push down with your thumb and forefinger until it's level with the teeth. Take the syringe, 50 mils, insert into the valve, push firmly, inflate the device, keep your thumb on the syringe and disconnect. Take the bag, place directly onto the tulip and ventilate. Squeeze firmly and at approximately this rate. Okay, so the tulip is designed for speed. You can see that was pretty quick. Basically, the construction is quite simple. For speeding up people like paramedics and ambulance or military, there's a headband so it'll completely stabilize itself. As you can see with the right angle bend here, it holds itself in and is doubly retentive with a headband. In terms of comparative size, you can see it's just that little bit larger than a Goodell. Yeah, the tulips come with flexible tubes so that they can straighten out, so that makes it easier for you to introduce it. In fact, it's actually just as easy to introduce it into a patient that's on the ground while you're standing up. That's not a coincidence. As a side-by-side comparison, you can see that tulip's roughly half the size of an LMA. That's because it sits in the oropharynx, so it doesn't go right down into the esophagus like the tip of the LMAs and I-gels do. It's significantly less stimulating as a direct result, which is why it can be used in semi-conscious states. Right, we were claiming a lot in this video, and the recommendation is to replace all Goodell masks as frontline airway of choice. Now, basically, I think there is evidence to claim that we are looking at something that could be the future of emergency medical responses, because only 5% of people who met Tulip for the very first time failed to achieve their ventilation parameters, but all of them succeeded in ventilating. And I think that is important. The only reason that these 5 didn't achieve the parameters is because they weren't squeezing the bag hard enough. And we were using, secretarial staff, nurses, paramedics, ODPs, some surgeons. We were using medical students. So basically, in terms of the function, the Tulip worked beautifully, but those 5% simply didn't squeeze, those 3 people simply didn't squeeze the bag hard enough. Now, this is an absolute contrast to what the Goodell uses, failing to achieve ventilation in 41.7% in total. Now, there were significant differences in the number of attempts that were made to insert each device, right? In humans, Tulip was 96.7%, Goodell's 78.3%. Everybody, not everybody, 77% of people preferred a Tulip in all the studies we conducted. Interestingly enough, whilst 25% of these BLS trained inexperienced users requested an assistance, 16.7% of them who failed to ventilate at all did not ask for assistance. Okay, so that's important. And that meant that the combined failure rate of Goodell and mask was 41.7%. Now, basically, as I said, 77%, 76.6% preferred using tulips, 23.3% preferred using Goodells because of the ease of use of a tulip. Now, basically, the statistical review showed that, our parameters was to ventilate in under 60 seconds and within 2 attempts. Basically, only 58.3% of Guedel and face mask users were able to do that, right? Of which 16.7 were total failures. 25% were inadequately ventilated, giving a total of 41.7% inadequate. Okay, those Guedel figures are in absolute contrast to the Tulip Airway figures, and this is why we're making such bold claims. With the Tulip Airway, 95% of the people were able to achieve the required outcomes. So that's ventilation in under 2 goes, 60 seconds, and parameters for CO2 and tidal volume. Basically, 5% weren't ventilating hard enough. There were 0 failures, and those 5%, those 3 patients, weren't pushing the bag hard enough, but that's part of the results. But the point was they were all successful in ventilating. So the study showed that when we compare the Tulip Airway to the Guedel, the BLS trained users on average with a Tulip generated 77% bigger tidal volumes than they were with the Guedel, 101% higher end tidal CO2 readings, 36% higher ventilation pressures, and there were absolutely no failures with a Tulip. So I bring it back to that question: do you think a single innovation could really change things? You know, that survival rates of 2%, I mean, directly impacting, you know, resuscitation and survival. Do you think that's possible? Well, here's a rapid deployment protocol for tulips. Okay, again, I reiterate, use a 60 ml syringe, not a 20 ml syringe 3 times, or you are going to get it wrong. You're going to underinflate. Okay, part of the rapid deployment, you got to know what size and what volume. Sizes and volumes are printed on the tube, all of them. Okay, so basically common pitfalls to avoid so you can maximize your success. Sizes, volumes. Now you notice blue and yellow are child, small child, large child, green, orange, red, adult female, adult male, large adult. In terms of volumes, you notice that there is basically 30, 40, 50, 60, up to 80. All right, but what's important is the cuff pressures of 50 centimeters of water throughout. Now, for 50 centimeters of water is 40 millimeters of mercury. That means it's the same as mucosal perfusion pressure, which technically means you can leave a tulip in for ages. But just get the right size for each patient and make sure you use a 60 ml syringe to fully inflate the cuff, and you will be fine. If you want to start using it, and I recommend everybody tries it in a mannequin first, okay, because otherwise you're going to get it wrong. I would use a green or an orange in a mannequin. If you're using true core mannequins, use a green size 2, use 50 mils and basically inflate it, and you'll see immediately what it does. The statistics say that basically if you use it in a mannequin once and are trained once, you're 100% successful, and that's every time. So, you know, I think it's advisable just to kind of, you know, 4 or 5 times put it in, take it out, inflate it, play with it, see what I mean, but do it in a mannequin first. Okay, basically you can see that this is rapid. It stabilizes the, you know, stabilizes the patients and improves those outcomes. Okay, in terms of what's what, I think what's important is video 2, because there are some third-party users, right, not my opinion, someone else's, consultants, who basically go through how this actually does make an immediate impact. Right, this is a recovery video that was taken with the patient's consent. And we asked her for this because it's, in our opinion, a complete game changer. This is evidence of return of laryngeal reflexes on self-extubation fully awake. Now, I'm defining fully awake as GCS 14 because this lady's still got a bit of slurred speech. But if you watch this video at the very, very beginning, and you just keep your eye out for this, between 1 and 2 seconds she swallows, so she clears her lower airway. But then what happens, she actually coughs at 8 seconds and then clears her throat again at 10 seconds. So she has her return of laryngeal reflexes, and this is proof positive. But she has also demonstrated she cleared her lower airway and her upper airway. Now, I think this is an absolute game changer, and if you don't, I'd really like to know why not.
Open your eyes, please. Yeah.
You pull that out if you want to, Anne. That's good.
Good. Excellent.
How'd you feel? You wide awake?
Yes.
How's your throat feel?
Okay.
Thank you very much.
I mean, that's proof positive. Okay, so I've shown you some evidence I don't think you can argue with. But in addition to this, if you go to video 2, there are 3 cases where 3 different consultants, 3 different countries, 3 different occasions, 3 different types of situations, so induction, recovery, you understand. But basically Tulip worked when no other airway devices did, so basically, you know, difficult airway society, plan A, B, C, or fail. So you're looking at cricothyroidotomy or some serious patient harm. All 3 of those statements are from other people. So, and I think anybody who reads those statements and doesn't understand that Tulip is the future, I think I'm probably just wasting my time talking to them. I've never seen evidence like this, and in fact the statistical trials show quite categorically more than once that Tulip should be given to everybody and that it's unethical not to use it. And I've got to tell you, I didn't expect that. But the point is the statistics all beat P is less than 0.0005. So, you know, that is the threshold. Now, additionally, all of these cases that I'm speaking about, they've all been published or presented, and that includes Euro Anaesthesia Lisbon 2024-5 and a World Military Congress Brisbane 2024. Now, what Tulip does is it buys you time. You can intubate through it, but basically what kills is the hypoxia and the acidosis, isn't it? So what Tulip allows you to do is stabilize quickly. All right, and the evidence is now showing that Tulip could well be that definitive airway management that you've been looking for. Now, Tulip is fast, it's intuitive. You don't need any skill really to, you know, to end up being actually better than a consultant. Basically, in our trials, it was shown that an inexperienced user is about 20% better than a consultant using who is using a Gadella mask. The inexperienced user using a Tulip is 20% better than a consultant. They're using about 11% less pressure. They're generating about 20% more tidal volume, and that's after 1 training session. So, again, I speak to the consultants. You know, I have to kind of convince you before you allow the the nursing staff and everybody else to use this. But this is designed to make life easy, and I've got to tell you, Tulip just makes airway management easy, even if you've never used it before. So, okay, where does the Tulip sit in an algorithm? You're in trouble. What do you do? Well, basically, you can try a Gadella face mask and an eye gel and all that, but basically, once they've all failed, feel free to try a Tulip. But basically, that sounds good, but you should basically, on the strength of the evidence like that, be using a Tulip in the first place. And the point is, if you use a Tulip in the first place, there kind of isn't a protocol, it just works. And if you basically want to intubate, you can go through it. Now, those 3 cases basically proved that Tulip stopped, at least 3 cricothyroidotomies. And again, if you don't agree with what I'm saying, please do let me know why. So this, again, could it replace cricothyroidotomy? Yes, it has, 3 times already. And then, watch video 2, read those third-party reports. I think that's important. So this is a Tulip Airway website. Everything you want is on it. Instructions for use, clinical research, references for the the stuff I talk about. There's photos, there's videos, everything you want to see. There's brochures, if you want to download one of those. But look, if you have any questions, feel free to either make a comment on the YouTube channel or go through info@, and we'll speak back to you. I hope that's useful to you.